morning, everybody. Good morning, welcome back. How's everyone feeling this morning? Tired? Good. Who had a good day yesterday? Good, nodding heads, nodding faces. So it's actually Nursing in the Community Week this week, and we have a little bit of a special presentation for those in the room, and we also have a live stream happening for people to join in across the country. So happy Nursing in the Community Week for all the community nurses out there and also here. So just a bit of a recap of yesterday, I suppose, to start with. Good day yesterday, a lot of fantastic sessions, and we'll back that up today with some more sessions. You know, we learnt a lot of things. We had a great welcome to country from Noongar Elder Marie Taylor, and I suppose for those joining us on the live stream, we acknowledge the traditional owners and custodians on the land that we are all on at the moment. We had some great sessions. The Headspace session yesterday afternoon, the interactive one, was fantastic. I think it's safe to say everyone had a good time, which is good. Lots of conversations, lots of meeting new people, and then finishing us off with a couple of drinks by the pool. So what a good day it was. And today we have that, have it again for you. So we have a plenary this morning, then breaking out into our concurrent sessions after morning tea, and then stick around. The wounds sessions this afternoon are fantastic. So we split the group in half. There's a theory in next door, and then a practical in here, and then we'll swap around and you get to play with all the dressings and all that sort of fun stuff. So stick around for that. So a couple of things just to kick us off. There's obviously the competitions we're running at the moment, which are going really well. So please jump on, use the app, climb up that leaderboard, and interact with everyone here with us. Also the social media competition. So hashtag APNO Roadshow 2022 and share it with your friends. And the prizes, the Foundations of Aged Care or Foundations of General Practice workbook. And if you want to have a look at these during the break, come and have a look at the APNA stand. Be more than happy to show you. So we're going to kick off again with the little video that we showed you yesterday morning, just so those people online who are joining us can sort of set the scene and get in the mood. And then it will be APNA CEO Ken Griffin straight after this.
Good morning, everyone. How are you feeling today? Is it feeling like your space yet? Are you feeling comfortable with those around you? I'm loving seeing the beaming smiles. It was yesterday, you were actually warmed up quicker than every other state group that we've sort of been to so far. You know, WA really representing. I'm loving it. Loving the high energy. I wonder whether we should start as we began yesterday, and hello to everyone online as well. It's great to have you here. There's a very, very good looking bunch of people in the room with us today, but it's great to have you online as well. But maybe we should start again, and bear with us with everyone online. We're just going to do something we did yesterday, which is, hey, why don't you find your winking buddy? Yeah, we're doing this again, right? Now, it shouldn't feel awkward to wink at them because you've been doing it for a day now. Can you see them? Give them a bit of a wave. Like, let's get a bit of movement happening. Can you see them, or are you missing with it? Now, I want you to give them that wink. Remember that kind of wink, not the other wink, not the other wink. And that wink, say, hey, your secret's safe with me. I appreciated the dancing last night, even if the cab driver didn't. So good to actually have some great conversations with all of you last night and really see just how good it is when you bring nurses together, because the amount of energy that creates is so good and you don't get enough of that. And it's so good. And for those who made it to the pool, I hope you enjoyed it. For those who went to the venue after the pool, I hope you enjoyed that even better, because we had a ball really getting to know you and some of the things that you're doing, which is so great, but also you know, some of the struggles and really helping work through some of those. And we weren't being polite when we said, hey, we're going to link you in with some people today to really give you some of the expertise and experience we've got to really help you solve some of those challenges as you go back. And also for everyone who wasn't there talking to us about those things, if you have that question, don't leave here today at the end of the day without actually asking those questions or having us take on some of that challenge with you to actually help you solve those before you go back to your practice areas. Now, as Mitch said, it's Nursing in the Community Week this week, so we really want to acknowledge them and acknowledge those who are online and those in the room. They are the second biggest part of primary healthcare nursing, and what I'm going to do is show you through, as I promised yesterday, the workforce survey, which gives us the best snapshot, in fact gives policymakers in Australia the best snapshot of primary healthcare nursing, because as we talked about yesterday, you're invisible in the data really, except for your APRA registration, which doesn't tell government what you do every day. So let me give you a bit of context. So this isn't our workforce data right now. This is actually the data that the government collects from your APRA registration. And once again, a shout out to the community nurses out there, because you can see that you are the second biggest group within primary healthcare nursing. So primary healthcare nurses, there's about 91,500 of you in Australia. Did you realise that? To put that in context, that's about 25 to 30% of the entire nursing workforce. The entire nursing workforce, we actually have about 422,000 registered in Australia, but they're not all working in nursing. So there's about 363,000 who are actually practicing as nurses. And you guys are 91,500 of those. So when you're feeling in your clinical setting where you may be working by yourself, that actually it's a pretty small world here. And I used to work in hospital, and actually I worked with a lot of nurses there, and it always felt like there was plenty of nurses around in a hospital, right? It doesn't feel like that in primary healthcare half the time, but you actually represent 30% of the entire nursing workforce, which is the largest health workforce Australia has. So a few other things you might notice there. If you're a general practice nurse, you're in the third largest group. There's about 13,500 or so. Correctional services, actually really interesting work being done there, and there's a lot of them because we keep locking people up, but there's a great amount of work that can be done when you actually have a population that's often quite marginalised. And then you can see how it works down there. So if you're in a school, or if you're in an Aboriginal health service, or working for the Defence Forces, actually we've got a really long tail that comes after that. So 640,000. You know how everyone you ever meet at a barbecue says, oh, there's a nurse in my family, or my sister's a nurse. Actually, when there's 640,000 health professionals, and actually nurses are 1 in 7 of those, no wonder everyone seems to know a nurse, right? You know, they should know a nurse. There's lots of you out there. So if there's one message you take away today, it is, hey, you're not a small group, you're a big group, and we really want to work on making sure we get that collective voice, so some of those policy changes we need to make so that you can do your best work. Actually, we need to make sure we act like the largest group in healthcare and for us, primary healthcare. So I'm going to run you through the survey results that we do. So we've been running the APNA Workforce Survey for just over 10 years. It started out cheap and cheerful. I think the first year we had about 208 respondents and we were high-fiving all over the office because no one had done it before, really. I think the best survey of primary healthcare nurses back then had about 148, and someone had got some data published in a journal and all that kind of thing. We reckon we can do better than that. And now we've actually grown. The best response rate we've had has been about 4,000 nurses. Why is this 1,062? Well, we took a really judicious decision last year, and think about how you're feeling this time last year, right? Everyone had wanted to survey you, they wanted to consult you, you were running really hard at work, you were smashed, right? We didn't want to do anything that would actually add to your pressure, so we thought we'd do a check-in survey that would just validate what the last survey, which had 4,000 respondents, would tell us, just so we could see if anything significant had changed. But I'm going to show you the results from that 2021 survey because I think you're going to be really interested in what it shows us. So bearing in mind we don't just survey members, anyone can actually respond to this, so we promote it far and wide through PHNs and health workforce agencies and social media, all that kind of thing. And thank you to everyone who did this, because if you did this, you're doing this on top of everything else. But this year, when we actually come back, we're hoping there's a bit of time that you can carve out. It takes about 25 minutes, it's online. No one gets up in the morning going, you know what I want to do? I want to do a survey. We recognise that, but what we guarantee is if you take that 25 minutes, we can convert that 25 minutes into a loud roar in Canberra so they listen to nurses. So when you see it come out, please do this, because we guarantee we can represent you so much more powerfully when you get involved. So let's start off with some of the demographic data. You can see from here you've got the two donut charts. The survey is broadly representative, so we can actually really break it down to showing that by location, and in WA, 9% of you actually answering the survey. It's great because you're from a really good mix of places, and that helps us make some more generalisation. You can see that we are RN heavy, and that's to be expected because we've got 81% registered nurses responding and about 11% enrolled nurses, which makes up the majority of the primary healthcare nursing workforce. And in primary healthcare, that's almost bang on the right percentage for the mix of RNs to ENs in primary healthcare. And it's great to see 2% of nurse practitioners here, because they're actually growing rapidly, and we know that everyone's crying out for more nurse practitioners as well, and we're welcoming them in. The problem is a lot of the system isn't designed for them, and we're actually trying to help the government redesign the system so we can use nurse practitioners much, much better as well. And then, of course, 6% of our nurse and midwife high achievers who are doing so much great work, usually in some of the remotest places as well, because we really need their skills out there, because you're not getting an obstetrician for love nor money, and it's getting harder to get the GP obstetricians out there as well. So they're performing such a vital role. So I'm going to spend a little bit of time on community nurses on this slide here. So this is what we can see about community nursing. And as I said before, they're the second largest sector in primary healthcare nursing with about 26,000 people. But this is what our survey tells us about you. So we ask a question just to set up this big table here, because it's not the best looking table in the world. But we ask a question which is, how often on average do you perform X clinical activity? And we ask about 72 different clinical activities that are within a nurse's scope of practice. And this is what you tell us. So you can answer, I do this daily, weekly, monthly, yearly, or never. So what do community health nurses do in their days? And so we've actually aggregated the daily and weekly results. 61% of community healthcare nurses doing wound care. 48% doing triage, because funnily enough, you see some really interesting stuff out there and you've got to escalate some of that stuff. SNAP assessment. So, this is the one that everyone kind of goes, I kind of just run through that. And this is the magic of nursing, right? When you're doing, the smoking, nutrition, alcohol, physical assessment side of things, actually really important, because it opens the door into virtually all the chronic disease management that you're inevitably going to manage. Recalls and reminders. actually growing area used to be that it was mainly general practice nurses who were going through their systems to really look at this, but community nurses increasingly doing more recall reminder. It's not just the go out to someone's house or to a boarding house or work in a particular setting. Actually, you're getting more and more proactive as a profession to actually call patients into you when you actually think they're at risk. Care plans. Does that sound familiar to everyone in the audience? So if you thought that you only do care plans in general practice, no, community nursing doing a whole heap of it too, and it's taking up a significant part of their time as well. That obviously leads, that's no surprising, to actually managing chronic disease, because that's what most of our care plans are built around. Infection prevention and control, 85%. Does anyone want to know what the other 15% were doing during a pandemic that didn't have anything to do with infection prevention and control? But this is the stuff that you do as part of your day, and you kind of think that's normal because this is really bog standard stuff for a nurse. Home visits. Now this is where community nursing tends to actually branch off from a lot of other nursings because they're not actually constrained to four walls of a clinical setting. You know, they're actually actively out there in the community. It's one of the best parts, right? Because this is where you get to play one of the most vital roles in a multidisciplinary team, because actually if a GP is telling someone, you know what, you need to eat healthier, but the community nurse goes into someone's home and finds that, you know, they're a hoarder, they can't actually even get to a fridge, let alone an area where they can prepare food safely. That's information that the team needs to know so they can manage that person better. A lot of advice given by healthcare professionals doesn't take into account the context someone lives in, and your eyes on the ground as a community nurse is vital for informing that. So then health promotion advice, 77%. A lot of the work is the most vital is actually the counselling people about how they actually do those 2% shifts so that they actually can change the long-term outcomes of their health. And then 42% case management, because you are actually engaging with other services, and that's backed up by the final one. The case management bit is really interesting because you're actually working in the multidisciplinary team, but actually that means that you're often the ones doing the adult physical assessments. Child physical assessments are a bit lower because they tend to be diverted off into other services, but the adult physical assessments at 52% just shows how much of your work dovetails back into things like the triage stuff, because your physical assessments are really actually leading to that onward action to keep someone coordinated. So really interesting things that our community health nurses are doing. To do this requires a scope of practice about that wide. That's about 6 foot, which means that you've got to keep your skills up, keep them nice and broad, because actually we're expecting a lot for you. Now the point I want to make for all the other nurses who aren't community nurses online or in this room, how much of this is familiar to you? Your scope of practice overlaps really, really solidly with what community healthcare nurses do. And one of the things walking around talking with people at the social events last night was actually this interesting theme, and it's not uncommon, but it's that sense of, I couldn't possibly be X kind of nurse. I don't have a certificate in X kind of nursing. But that's the beauty about primary healthcare nursing. Once you're in this sector, there is so much crossover with your skill set wherever you are right now with so many other settings that you shouldn't be ruling yourself out of actually different parts of nursing that you can be in. It's not a bad thing for you to consider other sectors you can work in within primary healthcare, or even thinking of going back into the hospital system. But one of the things that constrains our profession right now is the idea that you think it's a one-way door into another part of nursing and you don't think you can go back. And we're going to have to change that. At the moment, we lose 30% of all nurses 3 years after graduation. They leave the nursing workforce. 30% of every nurse we train as an RN leaves the workforce after 3 years. That's ridiculous because they either didn't know what they were getting into. That's a problem. Everyone should know what they're getting into. If you spent 3 years doing a degree, to only get 3 years actually paid work out of that at the end actually is a real problem. But also, we think that they don't necessarily see primary healthcare nursing, and I talked to you yesterday about the student nurse placement program, and Sam's going to come and talk to you a bit more about that soon. But we need to make sure that if a hospital nurse whose early career didn't know about primary healthcare, so thought when they were burnt out or just thought hospital nursing wasn't for them, but didn't know there are other parts in primary healthcare they could join, we could actually be diverting 30% of the new grads, early career nurses, into primary healthcare. And imagine what that would do as a bit of a game changer for all the preventative work we do, and imagine what the result would be for the health of Australia. So, this is what else our workforce survey told us. So remember yesterday, we were talking about, on average, 21 years as a nurse. You guys don't like to call yourself experts, but nurses in primary healthcare are experts. Over 2 decades on average experience as a nurse, and then over 10 years experience as a primary healthcare nurse. I reckon people should listen to what you've got to say. I reckon government should listen to what we've got to say. But if that wasn't enough, check out this. 32% of you have either got a postgraduate qualification or are working towards it right now. A third of you are actually have got or are going for a postgrad qualification. So anytime you want to use that phrase that we're going to burn out of the profession, which is, I'm just a nurse, actually, how many people with a postgrad qualification do you say, oh, you're just a... Yeah, actually, we need to start having a bit of professional self-esteem when we talk about ourselves, because this slide alone tells us that you are highly experienced. It also tells us that actually you're not sitting on your laurels, because a third of you are actually doing the hard yards to really get those extra qualifications as well. So let's talk about the stuff that we talk about in hushed or frustrated tones over a glass of wine with other nurses when we really start, stop being polite about some issues and we go, actually, these are the issues we have. And in this order: poor pay, burnout, stress. Let's talk about that. Because I put up the slide yesterday with the world on your shoulders, literally. People recognise you're carrying quite a load. And we shouldn't be avoiding this. So what are we doing about this? Well, there's several things. Poor pay. The good news is the union, which our data shows that 2/3 of people in this room are members of the union as well. In fact, on average, primary healthcare nurses have 2.1 professional memberships, and you tend to join the union, usually because they fought the good fight for you when you're in hospital, and you kind of keep that membership, and that's good. We don't play favourites. We don't say you have to be a member of us and no one else. You then tend to get a membership of an organisation by clinical setting, so in this case, primary healthcare nursing. You then tend to, but in lesser numbers, get a membership of an organisation that's specific to a clinical interest you've got. So it might be mental health, so you might be a member of the College of Mental Health Nurses. This is the interesting thing about nursing. Your scope of practice is that broad that it's almost like there's not one organisation that completely gives you everything you need. So what do we do when we recognise that? We actually say we should be working well with all those organisations. It's not a turf war thing, because that's just counterproductive, and if I'm honest, it's organisations kind of playing silly games that waste your membership money, because we should be focusing on things that help you. So how do we work with other organisations? Well, there's a challenge happening to the Aged Care Award right now, and that's going to lead to a challenge to the General Practice Award, and that's being run by the union, because that's the union's bag. We're a professional association. We actually can't negotiate that kind of thing on part of government because we're a different legal structure. But we've got the workforce survey. The ANMF doesn't have that data that we have, because when you do the survey, we ask about your pay and conditions, and we feed that to the ANMF, so that's actually directly informing the work that they're doing on the challenge to the award. So just because it's not our bag doesn't mean we can't inform it, because once again, you guys doing the survey gives us a mountain of data that we can use to advocate on your behalf, even if it's just playing a good game with the union. Burnout. Should we be brave and raise our hands and say, who's feeling a bit of burnout? Yeah. Look around, right? These are the people we need to support, and we need to talk openly about this. We can't be the martyrs. And the things that we're doing around that, twofold. There's a whole lot of advocacy work that we're doing at a government level with actually making the government recognise the strain that their policies and actually some of the taking for granted that they do of nurses is actually recognised in how they structure certain things. So, for those of you who follow me on one of the social media channels, I got on my soapbox. It's a fairly frequent event, let's be honest. But one of the things that actually came out 3 weeks ago was the Australian National Audit Office provided an interim report, an audit, on the vaccine rollout. The report's 140 pages. It's essentially the report card on how Australia has performed just on the vaccine rollout, not on the whole pandemic response, literally just on how many vaccines we ordered, got in arms and delivered. Now, I know that you'll all have some thoughts about that, and we've certainly had plenty as well. But nurses weren't mentioned in that entire report. Yeah, disgraceful is the word, right? Because what's interesting there is the National Audit Office, which is independent of government, basically asked for data and documents from the Health Department as to how they ran the vaccine rollout. Nurses weren't mentioned. Nursing was mentioned twice. And one of them was, it was recognised that when the government started the vaccine rollout, they should liaise with nursing organisations. Nursing first mentioned. The second one was, they actually worked with organisations, including the Australian College of Nursing, to actually develop the vaccine education modules before the vaccinations were rolled out. There's no mention of nurses anywhere else in that report. Epic fail. Epic fail, but remember what I told you yesterday about nurses are invisible in the data because the National Audit Office didn't go out there to look at what happens on an immunisation site or in a general practice or in any other clinical setting. They actually just asked for documentation from the department. And the department doesn't collect data on you, despite you being the largest workforce providing pretty much 80% to 90% of the vaccinations. In fact, when you look at the reports, they have 3 categories of healthcare professionals that deliver vaccination. They have general practitioner, they have pharmacist, and they have, and I love this category, other. Where are you? You're in general practice. And for those of you who work in a state-run vaccination centre, you sit in other. Guess where the majority of vaccinations are given? General practitioner. You're in there. Your colleagues in state centres, or if you did some contract work going into a vaccination hub, actually you're sitting in other. But either way, nurses aren't in there. Never. In the report card for how we actually got the country out of the pandemic through vaccination, you don't feature. I reckon there's a problem with how the government actually collects its data. We're working on that. We've also put in a please explain to the National Audit Office, and when we're in Canberra next, Karen and I will be having a few choice words with them. We're also going to actually try to educate, right? We're going to actually take them out to show them how vaccination works because they sat at their desks and took papers and documents from the Health Department to get their view of how the vaccine rollout worked. We need to educate these people because your role was significant and it's hidden in how we actually reflect on how we manage the pandemic.
They reflected all on the fact that they slowed it down so much because they insisted on GPs doing the vaccination. Even though there's that incredibly skilled vaccinating workforce in the nurses.
Well, we should talk in the break because, and for those online, the question was, did they reflect on how they slowed the vaccine rollout down? There's another report that's going to be done, which is actually on the entire thing, and we're actually going to get to that as well, because we're going to make sure you really are mentioned in that, but also the fact that general practice nurses were constrained to the 4 walls of a general practice clinic. Why would you line up healthy people who need to get a vaccine with unhealthy people who are actually just sitting in the waiting room? That doesn't make sense. We actually need to let nurses not be supervised by a GP when it's in your scope of practice to deliver a vaccine and you do it in so many other settings. We should be letting you go down the road to a hall, set up chairs and actually have better places where you can efficiently run people through. You shouldn't be supervised for something that we know you can do. And that comes to the burnout, right? Because burnout happens when you've got a heavy load and people aren't recognising or they're constraining your scope. And we need to make sure that government recognises that in policy. The surest fire way to burn someone out is not recognise them for the amazing work they've done, put hurdles in their way that makes it harder to get that stuff done, and just generally kind of constrains that scope because when you're looking at a patient in front of you, you should be able to do everything within your professional scope to actually make that person healthier. And that just leads to stress. So we actually reckon we can knock out the third one if we take care of the second one. But we also think that overall, this idea of money, it's actually the third reason that you consider a career. So we know money isn't everything, but we know that it's been an underlying thing for the whole time, which is why we're working with the union on that. So, episodic care. This is what the pandemic has fundamentally changed about what you do. There's less proactive stuff because you're running a mile a minute, keeping up with all the stuff that just comes through the door and the different changes and the, you know, go back to the vaccination thing, actually vaccination's not arriving on time, so you have to cancel everyone and then rebook them, all that kind of stuff. The cost of inefficiency during the pandemic and everyone sort of just rushing to make things happen means that chronic disease care is suffering, and we can see that clearly in the survey results. Interesting thing, and this shows on cardiovascular disease. And cardiovascular disease and its management is actually a numbers game, because you kind of think of it like a big filter. You've got to get almost a couple of 100,000 people in a community screened and managed in order to actually stop about 100 people arriving in hospital, because at the point that someone arrives in hospital on a cardiovascular presentation, they generally cost about $30,000 to $40,000. You can actually, you need to screen a lot to actually save that cost, because 100 times $40,000 in one hospital, a lot of beds, a lot of cost, all that kind of thing, and your superpower is actually avoiding that. But this is the stuff that's really actually taking a beating, because you think when you've got almost a third of you who are never doing CVD management at the moment, the last time I checked everyone still had a heart, this is actually the things that the pandemic has really impacted. SNAP assessments. It's actually such a routine thing, but when you start seeing a quarter of our workforce pretty much never doing them, actually no, that's the door that opens up the chronic disease stuff. But you don't necessarily have time to do that kind of thing, or you acknowledge that actually someone came in for something else, and I'm seeing a few things here that I do want to actually probe a bit more, but I don't have the time or the resources, or I've been constrained and I can't actually chase that rabbit down a hole. I'll see them next time, but of course you never know what's going to happen in the next time. But some interesting things came out of this data as well. So it's not good enough just to have data and actually understand what's going on, because the plural of data, the plural of anecdote is data, right? We need to get all your stories and bring them together and paint a good picture for government about what you're doing. But we got a full-time data analyst at APNA about 6 months ago, and he did some really interesting work, because actually it's one thing to play with your own data and look at what it says, but we actually started correlating or cross-referencing that data with other government data. Now the AIHW, so the Australian Institute of Health and Welfare, is like the big data warehouse for everything in health. And they have some really interesting stuff. In fact, if you want to sign up to their alerts, there's some amazing stuff that they will tell you about different health conditions in Australia. And one of the things they do is they look at hospitalisations from different causes. So we actually took our data on cardiovascular disease management, and we actually did an information request for hospitalisations on cardiovascular disease. And a really interesting thing happened. We could see a very clear trend, and the trend was this. In primary health networks, where nurses were doing more cardiovascular disease management, we could actually show a clear trend between those PHNs and lower hospitalisations from cardiovascular disease presentations in hospitals. Now, the government has never looked at this kind of thing before. And for those who love data, there's difference between correlation and causation, but one of my favourite nurse researchers, Julie Leach, says, actually, just because there isn't correlation or causation, you're not sure which one it is, you've basically got someone who's kind of waggling their eyebrows and pointing, going, hey, there's something over there and you should look at it. So we're looking at how we back this up, because, to use my funnel example, trends where nurses were doing lots of, for the last 10 years, as long as we've been running the workforce survey, you have been telling us between, in this case, last year's 34%, but it's been as high as 46%, tell us you are never or rarely used to your full scope of practice. The largest workforce in primary healthcare in the last 10 years, almost 50% of you, and it's only gone down to a third, tell us that you were never or rarely used to the full scope of practice. What does that mean for the health of Australia? We're not saying that you're sitting around for a third of your time twiddling your thumbs. We know you're not doing that right. We're just saying that the largest workforce in primary healthcare doesn't do the most important work you could be doing for the populations in which you work. It's not because you're shirking it. It's because there are constraints placed on what you do in your clinical settings. And it doesn't matter whether you're in community health, general practice, corrections, aged care, schools, you are actually not being used to your full potential. And when you're the largest health workforce, that is undeniably having an impact on how healthy Australia can be. Am I happy that this has come down from 46% 3 years ago? No. No, I'm not. Because I suspect needs must means that during a pandemic, we actually got an improvement of about 14% in how you were used. I'm going to wait for the next couple of years of data before I see whether that's maintained. But also, if it takes a pandemic to improve this by 14%, I don't know how many more pandemics we're hoping to have to get this down to 100% utilisation or get it up to that. But I think Australia fired its best shot with a natural cause that we had no control over to actually get this down to a third of you, actually only a third of you, which I say tongue-in-cheek, only like not being utilised well. Now just think of that, never or rarely used to your full scope of practice. Largest workforce, you wouldn't design a health system in a pink fit that actually goes, you know what, we're going to get the largest workforce and then we're going to go, hey, your scope of practice is like that, let's really crunch it down. Makes no sense, and especially with the constraints on our health system right now and all of the health needs that people are crying out for, this makes no sense and we're going to have to change it. So, I'm going to hand over to Sam very soon on student nurse placements because we think it's a really good story and we really want to get your involvement in it. But to finish off, I really want to show something for general practice. And for all those who look at general practice nurses and go, hey, you're probably in a conversation for about 5 minutes before they actually start mentioning MBS items and frustrations around funding and that. And you should have frustrations around that. But I want to just challenge some thinking, because certainly at APNA, we got some data that actually caused us to reevaluate how we think general practice is funded, because we've been there for ages saying, hey, actually, no, nurses should get MBS item numbers, and you should. There should be more of them. There should be things that actually allow you to work to your full scope and stop some of the silly descriptors that say a GP has to supervise your work. But an interesting thing happened during the pandemic. And that slow-moving health system that can never really change, apparently, like that's the narrative, actually a whole heap of things changed and they changed quickly. And we were part of a group that lobbied for general practice nurses to be able to use telehealth to actually do outreach to people in their homes, to actually get eyes on or ears on to people who were either too scared or unable to come into the general practice setting for checkups. Now, we thought this was going to be a bit of a silver bullet and also a really good case study that we could go back to the government and kind of prise the rest of the MBS door open for practice nurses, right? But an interesting thing happened. So, 2020, you got access, if you're a general practice nurse, to the telehealth item number in about July. And when we did this survey at the end of the year, only 21% of nurses in primary healthcare, in general practice, told us that they had actually used one daily. Now, picture this, general practice has said we're on our knees financially. They've just realised that they've actually got a retail business model. It's kind of like they suddenly realise footfall is actually how you make money. You know, you've got to have people literally walk through the door just like a retailer. And they've realised that actually a general practitioner on the phone doing telehealth actually isn't going to keep a practice afloat. So, hey, the RACGP and the AMA were going, you know what, suddenly let's make nurses not a cost, which they're not, but actually let's recognise nurses aren't a cost and let's actually give them the ability to create income for our practice. But this tells us that even with the peak GP groups lobbying for you guys in general practice to have access to an MBS item, and they finally get it, only 21% of general practice nurses were allowed to bill it. That means that an MBS item number isn't the silver bullet that we think it is, because culturally, if general practice isn't going to let the nurses use it, then there's an issue. Now, there's a few backstories to that. You know, the fact that it was only $12, and if you're reporting to a GP, then the GP is getting $8 of the $12, so the practice owner is actually looking at the $4 you just generated on something that might have taken 20 minutes. Actually, it's not that profitable either. So there's challenges in how they actually valued your time, because why should you be paid $12 for something that might take anywhere from 10 minutes to 50 minutes with someone who's at home scared in a pandemic? That's complex work, and it wasn't recognised in how they actually valued your time. But this shows us that there's a challenge with how fee-for-service works. And fee-for-service is you get this much money for doing that activity, because your work is more complex than that. And we need to find new funding models that recognise that too, because without that, we don't see your burnout and your stress levels coming down, because as long as there's fee-for-service and there's archaic criteria around how you provide that, that's actually not going to help you in general practice do the best work you can for the patients in front of you. So we're working on that too. But MBS is not the solution to the problems you see every day, but it's the system we have to work within right now. So we're trying to nut through that. And how are we doing that? Well, you know how you get into a conversation with a nurse and with each other, and suddenly you're actually running down the rabbit hole. Oh, and then there's this problem, and then there's this problem, and then there's this problem. And if you're speaking to a minister, the minister's going, I don't know what I need to do to fix things. Like, you've just given me a shopping list of stuff. So actually, we've got a really smart group of people in our advocacy team who have actually started working out, how do we present this better? Now, this doesn't look like, at the moment in this format, that it's any better than the rabbit hole that we go down with ministers if we don't sort of have key messages. But this is actually the start, because what we call this, it's like a spaghetti, well, we call it the spaghetti map. We've got one for every part of primary healthcare. And this is actually divided up so that you don't deal with symptoms, because there's plenty of people speaking to the people who make policy going, oh, and this is a problem and this is a problem, but actually they don't go up to root cause and go, actually, if they solve this big one, this other 8 or 10 issues would be resolved. So that's the point of the spaghetti map, because we can actually have a minister, and the number of times we have a minister or an advisor or a chief of staff come to us and say, someone said this, what's that about? And you go, actually, that's a symptom. If you follow that up to the root cause, you solve this one, and you also knock out a few other issues. And it actually helps us structure the problems of the health system in a way that ministers and policymakers can make different decisions, but better decisions, because let's go for root cause, let's not go for symptom. So, you're not meant to be able to read this slide, by the way. It's big, and it actually goes a bit bigger than this. But to explain how we're doing this, everything's colour-coded because it fits in a certain theme. So in this case, we've got about 9 of them, different colours, and so we group issues. But then we actually look at, okay, what one thing would solve most of those issues in that particular area? So one of the colours represents funding structures. One of them represents clinical activity. It's all that kind of thing that really makes up the challenges. And so at its most basic, there's things like the Poisons Act, which is different in every state and territory. Actually, that's a problem, because you actually, if you change state or territory, or God forbid you work near the border of a state or territory and have 2 clinical settings, actually, that's a real challenge, because you're kind of doing the mental gymnastics all the time. And why should those be different? Surely we should actually look at that. Your qualification is national. Surely the regulation you work under, it'd help if that was a bit more aligned as well. So there's all that kind of thing. So this is the kind of stuff we're doing to simplify all the problems so we can better present the issues and then use the workforce data to put that into context for the people who make health policy in this country. These are the 3 things we're working on right now. Biggest things that hold our workforce back: placements, curriculum and utilisation. Placements, because like I said yesterday, big university, 3,500 students, 8 primary healthcare placements in 5 years. We need to improve that. Curriculum, because if you're not actually teaching the next generation about primary healthcare, and we're 30%-ish of the nursing workforce, that's a real problem. But utilisation, it's not good enough that over the last 10 years we've had between a third and almost 50% of you say rarely or never used a full scope of practice. And the country is not as healthy today as it should be, because the utilisation issue has been ignored by policymakers. We're working on that as well. I'm going to be back in the last plenary today, and for those online, if you're able to stream, actually feel free to come back, but I know that you'll be busy clinically. I'm going to hand over to Sam, our founder, and we've been talking about student nurse placements and how we're actually going to tackle that first issue, because if we can't regenerate the workforce and enlarge the workforce, actually that's a real problem for you guys as well. But what we also know is that when you're involved as an experienced nurse in this program, it actually releases new energy in you as well. And you tend to actually stay or show an intent to stay 5 years longer in the profession because you've found something new that is yours, because actually you've got that amazing experience, on average 2 decades of it, that you finally get to pass on to someone else who really needs it, because the torch is going to be passed to them at some stage. So Sam, welcome up. Sam, our founder for those online, if you haven't seen her before, and Sam Moses.
welcome again to day 2 of our wonderful roadshow, and welcome to everybody online. It's lovely to have you as well. I'm here today to talk to you about our student nurse placement program, and I wanted to start with giving you a little bit of history as to why we got involved in it in the first place. So nursing's a journey, right? We all start off as students and we make our way through to APRA registration and then on into the big wide world of nursing. And that's very, very normal. And I don't know if many of you remember much about being a student or where you were placed and where you went and what that felt like. I do. I remember what that was like. And so I'm just balancing things here. And I guess, so first of all, historically, this was something APNA always wanted to be involved in, always. And it's, you know, we have a really, really big idea of lots of things that we want to be involved in, and it's finding the time to do it, right? And we all face that in our everyday life. So historically, we know there's a shortage of placements nationally, right? It's not a new problem. There's a backlog of hours for all of the student nurses who are studying in the country. There's high demand. There's always high demand for student nurse placements, and COVID made it worse. Okay, it just threw a cat among the pigeons completely. So we had Monash University come to us and say, basically, there were a lot of placement. The usual paths of placements were shutting down because of COVID, and they were in a bit of a spot, as were a lot of other national universities and TAFEs, and we wanted to help them. So they had about 200 odd third-year student nurses who were at risk of not graduating at the end of their degree. Terrible, you know. I said to the aged care group I was talking to yesterday, imagine being a student, going through, studying, handing in all your assignments and doing all the stuff you're supposed to do, and you get to the end and because you haven't had enough clinical hours, you actually can't get your degree. That would just be shocking. So basically we did a pilot program with Monash University, and we decided to place these students who were at risk, they were our focus, into greenfields, new primary healthcare settings where we'd never done this thing before. And we were greatly successful, and in the middle of a pandemic. So, you know, we had the world against us, and we did it anyway, and we did it really, really well. These nurses were able to graduate, which was fantastic, and we also worked with another, Victoria University came to us as well. So, you know, the demand started to grow. We also, where did we place them? So we placed them with all of the things up here on the slide behind me, but we also placed them with nurse practitioners. And what a great experience for a student nurse to be placed with a nurse practitioner and see how the peak of our professional body, you know, where we can take our career and have that as a role model and a mentor for them. So it was awesome. I'm going to just play you a little, that's okay actually. Did I do that? Sorry. It's a little video. APNA decided to create the student nurse placement program to meet the need of the workforce shortage that we're experiencing, to meet the need of the universities who often struggle to find enough placements for their students, and to promote the role of the primary healthcare nursing as a very viable option and career choice for nurses.
When I get the allocation for a primary healthcare service for my placements, I was a bit confused because I thought it's not going to be that busy, I won't be learning that much. When I came here, I felt it's completely different what I thought, and I'm experiencing so many different things happening here, so I'm loving that.
So I think this is a really good opportunity for the students to actually experience what it's like working in general practice. I'm very passionate about general practice, and I think it's a great career choice, again, for nursing students that normally wouldn't have that opportunity of seeing what our skills are like.
When a student nurse goes to a primary healthcare setting, it's actually a really great opportunity for them to have a relationship with that practice or with that primary healthcare setting.
One-on-one mentoring is really beneficial for a student because we have an instructor beside us throughout the shift. So we get feedback for each and every little thing we do, and that is really helpful for us to improve our knowledge and improve our practice.
One-on-one mentoring is a really good opportunity for the nursing students to be able to consolidate, ask questions, be confident in what they want to learn, to try and get them ready for what life is like in general practice, because it's not the same as hospital, it's not that acute at times.
I feel like primary health care is really beneficial to start the career because we get a lot of opportunities and we get a lot of time to learn things slowly.
Initially the student will start off very shy, quite sort of standoffish, they'll stand back, and then give them a little bit of a leeway, a little bit of independence, and you see how they just progress from somebody who initially was first, oh my gosh, I can't do this, to somebody that just confidently gets there and really just does an amazing job. So seeing those and seeing them smile when they know they've achieved that is really rewarding.
It's not uncommon for student nurses to be actually offered a job back at the practice or back at the facility where they've been working on their clinical experience. So I mean, it provides that really wonderful opportunity for them to almost try a staff member before they employ one.
Being here, doing placements was one of the greatest thing that happened in my life because they offered me the job at the end of my bachelor program.
And it's about creating a pipeline of young nurses coming through the university system to be able to perhaps choose a career in primary healthcare nursing when they get to the end of their degree.
So that was one of our lovely members, Lisa Taliano, who took that student, and it's exactly all of those things that you saw in the video. It creates a pipeline of young students, enthusiastic students coming through your door in every setting, and you find one that you really click with that fits with the culture of your practice, and you can nurture them and mentor them. The point of difference between what we do and say what hospital settings offer, it's a one-on-one relationship. They do get to learn. That student made a really important comment about doing it slowly, so they get to learn at their own pace. They can't really hide in amongst, if they're not great at something. I think in groups of 6 or more, they can sort of be lost in the process of what they're learning. In this situation, it's them. They're right there. They get to ask their questions, and they can't hide if they're shy and they can't say what they need help with. So it's such an amazing program, and the supervision and the mentoring and everything that's offered by you guys to these students is it's priceless, really. And there's been very little research conducted about the effect of primary healthcare nursing placements in Australia, but there was one study done in 2013 with about 31 students, and they were sent to rural and remote locations, and it looked at the impact and the effectiveness of primary healthcare nursing placements. And what it showed was that there was a marked increase in the confidence of all students across all of the nursing domains. It also showed that there was a longer placement is better, and of course that all makes sense, doesn't it? When we go on a holiday, it takes a week to unwind, and then if you only have a week off, then you're back at work the next week. So same sort of thing goes with student placements. The longer they can be there, the more they find their groove in the stuff that they're learning. That support is a key factor. Well, we have that absolutely on top of that at APNA, with you guys being their mentors and their supervisors, and you guys have got us to fall back on as well. So the support, is really critical. It also showed that preparation in the earlier stages before they go on their placement is really critical as well. So that's orientating them to primary healthcare, because they don't know what they don't know, and what they have and what they often have in their head as where they think they're going and what they're doing is actually not always right. So you give them some information to take on board, and they come out the other end knowing about primary health care, because it's not there for them to touch and feel and see in the universities and the TAFE settings as much as it needs to be. So that's why, another reason of course why we're doing this, because we want more primary health care nurses in Australia. There's a national workforce shortage, and this is one of the ways that we can meet that shortage, without a doubt. They also showed that the increased diversity of the rural and remote placement enabled the students to expand and extend their knowledge and skills, and it increased their work readiness. So what we were preparing them for, they were much more ready for. So what do you need to be involved in our placement program? You need to be a registered nurse. You need to have full-time hours. Now, if you don't work full-time, that's not a problem. If you job share, that's not a problem, because what we can do is we can share the burden of the student's learning across 2 nurses. We do that all the time, so that's not a problem. And of course you need a desire to do it and want to be involved, but that doesn't seem to be a problem, which is lovely.
So I've been in general practice now for 20 years, and in that time I've been able to do a lot of amazing things. So I think that building the relationship with the student and trying to help them consolidate some of their skills, so whether it be that they build confidence talking to patients, whether it be that they can really work on their pathology, removing his sutures, they're quite acute skills, and it's a one-on-one opportunity where they can, have that, I suppose, experience and, really learn what it's like in general practice. And you see how they just progress to somebody that just confidently gets there and really just, does an amazing job. So seeing those and seeing them smile when they know they've achieved that is really rewarding. The support from APNA has been really, I've got to say, A1. It's been superb. It's very rewarding. I really enjoy having students on placement with me. And I think, again, just giving me that, it's almost like a new leash in life. And it's about, giving the encouragement and really helping the student, see what else there is in nursing.
And so I'm just going to go back to this other slide. There we go. So a little bit about why to be involved. We have a supervisor handbook which is on display out in the foyer, and that also comes with exclusive educational material for you whilst you're involved in the program. You can claim some CPD points through this as well, and we will provide you with a certificate for that. We pay the practice for taking the students. And as Ken mentioned earlier yesterday, we have no funding for this program. We are funding this ourselves, but we try to pass that on to the practice. Now, a few of the practices might put that in a bucket and give it to you for your CPD education. They might not. They might put it towards a conference for you to attend at the end of the year. But if you take 6 students across a 12-month period, which is what most of ours do, there's usually about $2,000 at the end of that that you can use on your CPD, and that's up to you to help negotiate, and we can help you negotiate that with the practice where you work as well. And of course, we've got our online community, so myself and other nurses at APNA are there to help you if you need it as well. And we have special nurse events as well. We're doing one on supervision just coming up in October, actually. I think it is October, November, anyway. So it's really simple to get involved in as well. Literally, you just, on the page in your book where my talk is today, you scan the QR code, and that puts you into a registration form where you can just register your interest in being involved in the program, and then our team will reach out to you about that. There's an agreement form that is signed by the practice, and then a financial form so that we can pay you at the end of it. But I'd love to talk to you about it. I'm again here all day today, so come up and see me if you've got any other questions. Thanks for listening, and Ken, I'll hand back to you. Thanks, everyone.
Do you want some help? So I mentioned yesterday that we're not going to ask permission to do this kind of thing. When we see a problem, we're going to tackle it. And actually getting that next generation through is something that our education system has a blind spot for when it comes to primary health care. Good, that is on? I wasn't sure. So we're not complaining about it. We're doing something about it. We're actually going to build that up, and we want to build it into a national program that is able to really foster that next generation coming through and give you these opportunities to bring through that extra well-qualified support. We made an example of general practice in that video. We place them everywhere. school nursing, we actually place them in correctional settings, and tell you what, when it takes you 30 minutes just to get into work a day, actually you know you're in correctional nursing, right? When you can only bring in your lunch in a clear bag, you know you're in correctional nursing. But it's that kind of thing, ADF, that kind of stuff. No one's really doing placements in ADF. Great experience, you do some really cool stuff there. And the number one issue that we have when we're doing student placements is actually clearing that blind spot in the curriculum of TAFEs and universities, because I can't tell you the number of times Sam and I have been having conversations with a dean of nursing that goes something like this: your placements don't fit the curriculum. Well, newsflash, I thought they meant to be training them for the workplaces that were out there. And this is the blind spot, right? This is the, hey, we're used to training for hospitals. And actually, most people educating in TAFEs and universities are hospital trained as well, so they don't know what they don't know. So what we're actually showing, because Sam talked about the research, is we're actually showing not only how much the students love it, and also the benefits of one-on-one supervision, because they don't get that in a hospital setting, so they actually are learning more and coming out more confident. It's really good to see. We're actually aiming to place over 1,000 students next year. We're probably going to do somewhere between 500 and 700 this year. It all started because during the pandemic there was a need, and finally the university was saying, hey, can you help us out? So we're going to build it up in WA. We'd love to get your support for it if you're interested. Like we say, there's a number of things that are really sort of beneficial to this. We're trying to get policy support that would actually mean you get paid better for it, but at the moment it's kind of a stipend thing, but we wrap a whole lot of other great support around it as well. And with the Perth conference next year, we'll be able to really bring you together and actually make sure you can see who else is doing it, and really sort of make sure that community of practice for everyone doing it here and nationally is really well seen. And for those online with the stream, actually, we'd love to hear from you as well. So it wouldn't be right for us to leave you today, and we're in the final stretch, without having our fearless president come up and tell you about what is the policy stuff we're doing, because we've talked about the data, we've talked about one of the really practical solutions we're doing to really resolve one of the biggest issues, which is the placement and the curriculum thing, because don't tell anyone at university. Placements are actually the Trojan horse to get the curriculum changed, right? So it's pretty obvious, but we feel pretty clever about doing it this way, rather than going curriculum, then going placements. But what I want you to take away now is really how are we actually making sure we bring this together when we're actually hassling everyone in Canberra and also in your state health departments to really make sure, if you're a community nurse or a primary healthcare nurse, whichever part of it you're in, what are we saying to them? So I'm going to hand over to Karen.
I will give you the polite version of what we say to them. So it's been a fantastic couple of days. We've still got lots to do today. And as Ken said earlier, Nursing in the Community Week has kicked off this week. And the good thing about primary healthcare nursing is there are so many kind of disciplines or subspecialties, but we all interconnect. And I think that's really an important issue. There's a generalist thread of everything that we do, and then the build onto that, where the niche areas that we like to work in, but it all interconnects. And I think one of the most important things, particularly for those nurses that go into homes to visit people at homes, is the continuity of care, but also you're the people that are most likely to see where the gaps are. You're the people that are most likely to go, oh, they're not managing. You're the people that are more likely to then upgrade or, push the level of support that they need up. You're the people that link them in with primary healthcare, other services like their general practice, so that you've got the wider team on board. And I think that is one of the most critical roles that you do. I loved doing home visits when I worked in general practice. It was one of my favourite things, because you actually got to see how many cats are there in the house, and are they surviving on sponge cake and jam sandwiches? And there's a few of them. Do people need help with home care? Who's helping them to manage their lives? Who's helping to support them to keep independent? And of course, the things like wound care and other physical supports on an ongoing basis that community nurses give, That saves millions and millions of dollars a year to the health system. And I think, and the important thing is that you are often the people that link with, you can link with the tertiary system, you link with the primary care, the GP system, and you help to actually make it better for people. A few statistics that some of you might be interested in. Last year, 154 million people or Medicare items were billed to Medicare through general practice. Allied health, 24 million visits on MBS items. Another 52 million visits privately paid for and reimbursed by health insurance. And that's not counting then the visits where people just paid out of pocket. 50% of the population have a chronic disease. Another 20% of them describe themselves as having 2 or more chronic diseases. And preventable hospitalisations, 748,000 preventable hospitalisations, 1 in 15 admissions, 1 in 10 bed days in hospital was a preventable admission. Diabetes alone costs the nation $14.6 billion a year in medical expenses, lost income, lost productivity. So the job that you do with early screening and identify where the gaps are and contributing to preventing people going to hospital is one of the most important roles in health in this country. We don't get enough kudos for that, but what we do and what the greater primary care system does is we keep people well and keep them hopefully out of the hospital system. So health reform, the type of reform that's happening at the moment. So many of you have been, who was in healthcare homes? Yeah? So Helen. Healthcare homes was a great model in that it was really flexible care. So there was pools of funds given to practices to look after a particular patient, and the patients were risk stratified. And the care was flexible. So if the patient didn't need to see the doctor, they came, they saw the nurse regularly. Nurse could do home, do calls to home. There was no worry about how to charge that because the practice was paid up front for that. So really liberated a lot of the nurses in those practices. And at the end of the healthcare home trial, we had a big meeting in Melbourne, and I've never seen so many proud multidisciplinary teams talking about the wins that they had with healthcare homes. Funding model, but the actual care model was really good. What we're doing in the current round of health reform is looking at models of care. So things we're going to look at, we're looking at voluntary patient enrolment, and which still isn't firmly defined, but it's basically meant to fund continuity of care. And one of the arguments that I always make at these meetings is, what's going to happen to the patients of nurse practitioners? Are they going to be funded with that extra funding support? What happens to those towns where there's only nurse models to make sure that they don't miss out on additional funding? So while there's lots of talk for funding for general practice to do continuity of care, we need to always make sure that we're arguing for patients of nurses, patients of nurse practitioners, homeless people, people who aren't attached to a practice. So APNA, we're arguing for that. We know that there's lots of areas of market failure, and so we'll be looking at models where we move to salaried models for health professionals, and that'll be a lot of conversation between the states and the federal government about how we fund that, to make sure that towns where they can't afford to run on fee-for-service don't lose their health support systems. We need all health professionals working to their full scope of practice, whether that be doctor, nurse, healthcare assistants. They need better training, better recognition of the skills that they have so that they can work to a higher level. It pushes the nurses up to a higher level, that pushes the doctors up to a higher level. And it'll make the whole system much more efficient. So we just really need to look at how we do that, quality, safety, and as well as, you know, making the system work much better. Workforce is also a big part of what we're talking about. And some of the things that are happening, the National Nursing Strategy has stalled. So in December last year, the chief nurse contacted all of the peak bodies to say, Minister wants to move forward with a national nursing workforce plan. Great, we haven't had one for decades. And, but we want it done and dusted in 3 months. And we went, I said, sorry, medical workforce had 2 years, rounds of consultations before theirs was prepared. You're trying to tell us that for 450,000 nurses, you want this done and dusted in 3 months with future planning. And we all said, no. I actually told them it was insulting. So that's kind of, now they're looking at properly mapping the workforce. But, you know, here we are now, more than halfway through the year, and we haven't had a report back on how that's going. The Council of Deans, which is on the organising committee, they said, we haven't met. So it's just stalled. So that will be another push from the peak bodies. I think all of those things that you've heard today where we've talked about student nurse placements, transition to practice, support for the workforce, it really is looking like, as a peak body, we are driving the workforce development. It's not coming nationally. We'll hopefully push it to a point where it will come nationally, but we'll battle away until we actually get a better deal and much more formalised planning for this sector. The states cover off on tertiary system. They've got some really sophisticated workforce plans, but at a national level, it's poor. A couple of other things that I would like to say to you, and that is we need you. You do the most important job, keeping people well, stopping them getting sick, keeping them on track and keeping them out of hospital. We need you to tell your story, and we need you to talk about what you do in meetings, in public places, so that you're much more visible, and the things that you do to contribute to people's health. If you get a chance to be on a local PHN committee, put your hand up, because you've got lots to contribute. As Ken said before, you are a highly experienced workforce, and again, it makes you visible. And when they hear about people in forums, what you do, they realise your value. So that's also part of it. Put your hand up for APNA advisory committees, because again, this is the Brains Trust and we need you. And there are so many opportunities coming to APNA for advice and for asking, you know, how can we contribute? And I think lots of people have said workforce survey. Please complete the workforce survey, because not only can I tell the government about what we're doing, with that strong data, I can shout it at them at what we're doing, and often I do. And vote as well. So next year, there'll be elections next year. We've had some fabulous WA representatives. Helen down there has been on the board. I'm getting teary because Jane Butcher is on the board and she's a very close friend of mine. So, you know, we've had some good WA candidates. Make sure you put your hands up and vote for next time, for next year. And on that note, I will say well done and keep up the good work, guys.
So we're done for the plenary. What have you heard? You're undervalued. You're doing great work. The health system needs you because the country isn't as healthy as it can be. We're going to talk a lot more about this and why the entire primary healthcare workforce is actually essential to making sure the health system, but also the economy doesn't collapse in the next 20 years. That sounds dramatic, and it is dramatic. It really is, because the country's going to have to make some really big choices in the coming 5 years to set up the health and the future economic stability of Australia. And I'm going to show you why you're integral to that and why primary healthcare is only getting bigger. It feels like it's the small forgotten child in many ways. That's not going to be able to happen because there are macro forces coming to change that. We're going to need all of our primary healthcare nurses, so it doesn't matter whether you're in aged care, community health, general practice, school nursing, correctional nursing, home visiting, palliative care teams, all of the different parts, and there's so many more of them within primary healthcare. We actually need to get things right because otherwise the country isn't just going to suffer on their health front, they're actually going to suffer on their financial front as well. I hope this has given you a snapshot of how we convert your individual responses in the workforce survey into a powerful message, because I think, judging by looking at some of the faces and some of the screenshots you're taking and some of the notes you're taking at certain points, there are certain things you didn't realise about the impact you have every day in your practice. And if I could add one thing to what Karen said, along with the well done, you do your great important work, is when you start looking at where nursing and primary healthcare intersects with state and territory governments, we're actually doing a lot of work there as well because they control school nursing, for example. And Kate's here. It's been great to see Kate, huge advocate. If you're a school nurse and you haven't met Kate yet, we're going to have to actually link you guys before the end of the day. But we're actually looking at how we get a school nurse in every school. And we've got to lobby that not on a Commonwealth level because that's not their bag, it's actually the state and territory government level. But imagine what you could do if you had someone with your experience in every single school in every state and territory. You know, this is the stuff that sets kids up for life. It also takes the weight off general practice because they'll be making better decisions about their health and that kind of thing. We can do so much there. So we're going to let you out to the break to get some tea and coffee and to recharge and have great chats. Get your drinking buddy or your winking buddy, however you want to describe it. You know, make sure that you're speaking to people. Don't be out there alone. And if you want to talk to someone from the APNA team, there are so many great people here who can help with some of those challenges that you're thinking you want to solve in your clinical setting. Make sure you're not a stranger. Thanks for listening. Thank you to everyone online, and we'll see you in the next session.